Interests focus on speech pathology management of transgender individuals, perceptions of gender, extraclinical measurement of voice, voice-related impact on activity and participation, and you will hear more about her special work on transgender voice. She has published and presented extensively on it, as I mentioned before the break when I introduced Jenny Coates. And so please help me welcome Ms. Dacakis to talk about evaluating transgender voice and communication.
Thank you very much, everybody. I would also like to thank the Voice Foundation for the fabulous conference program, especially for supporting this session. I would also like to correct an error, and that is about Jennifer Oates and myself. We haven't worked together since 1980, it was 1979. She makes me say 1980 because she thinks 1979 makes her sound too old. I would also like to say that the work that I'm presenting on assessment is applicable to trans and gender diverse individuals, but my examples will be mostly referring to trans women because that's the group that we mostly see. And there was something else I wanted to say. Oh yes, that I hope that when you leave this session, I'm actually confident that when you leave this session, you will be aware that you have a lot of knowledge and a lot of skills that are transferable to working with this unique population. Okay, so I'm going to talk briefly about case history, assessing communication, and assessing voice. With the case history, the main aims, of course, are to establish client-centered goals and to make sure that you identify facilitators and barriers to achieving these goals. The case history is based pretty much on a standard voice case history, so you still want to know about general health, voice use, employment, vocal load, etc. But you add a transition. You obviously add transition-related questions such as the impact of cross-sex hormones, situations in which the individual attempts to use their gender-confident voice, and a range of other points. You need to know the referral source because the referral source will give you an indication of the motivation of the client, but also, more particularly, whether the individual is involved in a gender clinic, a gender program. Probably the most important thing you need to know is the individual's preferred name and the pronoun that they use. You will find that clients attend for voice training at different stages of their transition. So you need to be prepared for the fact that you might have someone who comes presenting as a male, a woman who is presenting in male attire, but prefers to use a female name and a female pronoun. So it's very important that you adjust to this situation. Often the gender assigned at birth and the self-identified gender is evident, especially if you are working in a situation as we are, where we see people who assign male at birth but who identify as female. But sometimes if you're working with non-binary people, it's necessary to actually ask the person the gender that they self-identify with. It's a matter of respect and a matter of obviously feeling safe in your environment. The important questions are to find out the support for the transition of voice, the support for transition, but also the support for transition in voice in particular. Do family, friends, employers support the transition? Do they support the transition, the vocal transition? The support for transition, obviously, well, on a smaller, in a smaller way, it gives you an indication of the opportunities for practice, but it also may give you an indication of an unstable or a difficult psychosocial, psycho-emotional situation that can impact significantly on the progress of your voice training. Some people more recently are introducing a gender congruence scale in their assessment, and we haven't introduced it yet, we are considering it. So the gender congruence scale looks obviously at the congruence between the gender identity and the individual's body. Some examples of questions, and this isn't the full scale, include my outward appearance represents my gender identity. I experience a sense of unity between my gender identity and my body. I do not feel that my appearance reflects my gender identity, and so on. I'd like to see a gender congruence scale that includes some questions about voice, and that could be another project. In terms of language and pragmatics, there's minimal guidance in speech pathology literature for the assessment of these characteristics for the transgender population. There's some information in the Adler-Hirsch and Morda book, and hopefully a little bit more in the soon-to-be-released Adler-Hirsch and Pickering book. What we tend to do is record a 5-minute conversation, plus ongoing observation, noting features that Jenny referred to, such as the use of tag questions, the use of descriptive adjectives, and so forth. But the key point here is, because we don't want to impose behaviours for which there's not a lot of evidence for and for which may be stereotypical. The key point is to make sure you get the client's perspective of the authenticity of these features for them. So what we tend to do is we give them a checklist to take home and say, take this list of behaviours home, have a look within your own social milieu, and see whether the women around you are using these different features, and see which ones you think might be suitable for you. So it's very important that your goals are client-driven. With regards to non-verbal behaviour, again, it's observation during your initial assessment, but following the guidelines of Hirsch in that Adler book, 2012, you start off by having an overall picture of the non-verbal behaviour, and you gradually build up a picture in the ensuing weeks. So Sandy recommends getting a general overview followed by a systematic evaluation of sections of the body. So looking first at facial features, then maybe at gestures, and then at body posture. Again, you're looking for things that will distract and possibly result in negative consequences from listeners and observers. And some things are very, very obvious. For example, if I have a client who sits down in a chair, sits back and puts her hand on her breast, I have to say, actually, women don't tend to do that. So there are some obvious things that you need to note. In terms of articulation, I suspect a lot of you here have really good voices, and I bet you have fabulous ears. I think that, gross imprecisions, sound substitutions like thumb for thumb, etc., you can observe it when you're with a client. I don't think standard articulation tests are necessarily necessary, but they may be depending on the actual presentation of the individual. But basically you're looking for the vowels to see about gentle onset, vowel prolongation, and for consonants, gentle onset and precision. Jenny also referred to the spectrographic analysis that you might want to do when you're looking at articulation. Voice assessment, a lot of what I'm saying will be second nature to you, but I will still go through it quickly and just point out a couple of aspects that you might want to consider when working with trans and gender diverse individuals. Laryngeal imaging. Well, there are two schools of thought. With regards to general voice disorders, you wouldn't see a client without sending them for laryngeal imaging. With regards to the trans and gender diverse population, we tend to not send our clients automatically. We're in a university setting and we have to weigh up the cost of the burden on the client who is attending multiple medical sessions. We don't need to give them an extra burden. We're listening to the voice, we're taking a case history, we're undertaking an acoustic analysis. Obviously, if we suspect that there is a voice problem, we will send them for laryngeal imaging, but we don't do it automatically. This is quite different in other places. For example, at the Karolinska Institute in Stockholm, they have an ENT clinic with the speech pathology clinic, so all their clients go automatically. And I know that a lot of private practitioners send their clients automatically. So it's really whatever the person feels is their philosophy on this point. Okay, so the voice sample that we take, this will be very familiar to all of you. We take the voice sample of the sustained vowel, reading the standard passage, ascending and descending glissandos. And the main point that I would make here is that we ask the client to produce a voice that's comfortable in their everyday pitch and loudness, but we also find that if they've made any attempts to change their voice, if they've made attempts to change their voice, I would also ask them to produce the best, in the case of the trans woman, the best female voice in a reading sample and also analyse that. Pitch and intonation. Well, this is, as I said, standard for all of you, that if you're acoustically analysing pitch, you look at the mean, modal, standard deviation, minimum and maximum. There is nothing different here other than the caveat that I said before about making sure you know whether you're assessing their everyday voice or a voice that's already been modified. And with intonation, the gross measure is standard deviation, but a more detailed analysis will include acoustic analysis of pitch contours. We like to have the individuals to take a phonetogram. This enables us to look at vocal capabilities. It's also a good way for the individuals to have feedback to help them achieve their maximum range, so we can see what that is. And it's also not a bad outcome measure. Caveat here is that some trans men and women may find it difficult to use the extremes of their pitch and loudness for fear of producing their gender incongruent voice. And if I just actually go back to the glissando, the ascending and descending glissandos, you'll have clients who will not want to go down to that lower pitch, just because it reminds them of their birth assigned gender, and it's very important that you don't insist that they go down there. Again, you have to weigh up the cost of seeking that information. And I've had some clients, this is when we decided we wouldn't ask people to do that anymore. We had one client who had a very distressing reaction many years ago to being asked to go down to their lowest pitch, and so we don't do that anymore. Learned the hard way. Okay, so just a phonetogram of one of our trans women to give you an idea of what that might look like for anyone who hasn't seen a phonetogram. So you have the intensity on the vertical axis and the hertz on the horizontal axis. And here's an example of, I'm sorry I don't have a pointer, but you can see the external square is the vocal range profile. This is the pointer. It's a very nice colour too. Okay, so here we go. There's the male voice range profile, and then we have the, here we go, here is the male speaking range profile. the female speaking range profile, and this is from one of our studies in 2010, the average of the trans woman profile. Okay, voice quality, again something you do with all clients, acoustic measures of voice quality, and you can choose the measures that suit you, so spectrographic measures, jitter, shimmer, harmonic to noise ratio, orchestral peak prominence measures. These are examples of anything that you can use. Resonance, again, something you're probably used to assessing, spectrographic analysis of the formants, orchestral peak prominence measures and long-term average spectrum. So they're the acoustic measures, and if you've done any acoustic measures for any other client with voice disorders, you'll see that you can do an acoustic analysis of the voice of these clients. In terms of auditory perceptual analysis, again we use standard protocols for assessment of pitch, voice quality, resonance and intensity. If you're in Europe, you're probably using the GRBAS. If you're in America, I think you're probably using the Cape V, and if you're in Australia, you're using the perceptual voice profile of Oates and Russell. I like the profile because, I don't know if you can see it, but we've got pitch there, loudness and quality, so it's quite comprehensive, and it also has a perceptual resonance profile. This profile hasn't been published though, so I need to tell you that. In terms of subjective measures by clinician, this is from Hirsch and Gelfer. You can use a VAS type scale for resonance. So in this case, there's masculine posterior around a chesty resonance on one end, and this is not presented like this. I just couldn't fit it in one line on the slide. Sorry. So you've got the arrow, but it's a VAS scale with 5 being feminine forward, upper larynx and head resonance, and obviously if you're seeing someone, a trans man, then you would change those around, so feminine, etc. would be the 0, the masculine would be up to the 5. The other subjective measure that we undertake is related to gender, so the clinician might rate the dichotomous male or female in terms of the speaker, but not necessarily, oh, that's got an orange. Not necessarily ask the client to do that. Voice femininity, I'm going to speed up now. Voice femininity ratings on visual analog scales, you can use something like very feminine to very masculine or very male to very female. We tend to use this rating scale, so currently my voice is very female, somewhat female, female, gender neutral, male, somewhat male, very male, and my ideal voice would be. Along that, this gives us a bit of an idea of expectation in terms of voice as well. We look at femininity because clinicians' ratings actually provide an indication of how the voice is perceived by the public. We also rate voice femininity because there's a good body of evidence that says that if the individual rates their voice femininity as low, it is associated with more frequent experiences of voice negatively impacting on the individual. Okay, so I think ratings of voice femininity by both clinician and client are quite important. Then we go to self-report measures. If you've used self-report measures before, you would have used the VHI or any number of voice measures. The individual's perception, this is the voice, self-report voice measures are particularly important for this group because individual perceptions of their voice and its impact is determined by a complex range of factors that you can't assess all of them, you can't know them all, there are too many. The acoustic measures do not reflect the impact of voice on the individual, so that we've had so many years of focusing on fundamental frequency that it doesn't tell us anything about how the voice is impacting on the individual. The speech pathologist rating of voice femininity do not necessarily reflect the impact on the individual. There's some research there that's a little bit contradictory, so we're still saying that it's not necessarily reflecting, and we need a bit more to confirm that, I think. The current voice self-report measures for cisgender populations don't include the unique experiences of transgender people. There's no validated questionnaire for trans men, and there's no questionnaire for those who do not adhere to the binary view of gender. We do have a questionnaire for trans women, developed by yours truly and Sheila Davies. This is a 30-item tool that captures the perceptions of trans women regarding their vocal function and the impact of voice on their everyday lives. And the individuals read the statement and respond with how frequently the occurrence occurs, so never or rarely, sometimes, often, usually or always. The examples of some of the questions: I feel anxious when I know I have to use my voice. My voice makes it hard for me to be identified as women. I feel discriminated against because of my voice. My voice gets croaky, husky, hoarse when I speak in a female voice, and it distresses me when I am perceived as a man because of my voice. The questionnaire has been found to be reliable and valid, reliable in Portuguese, Swedish, English that have been published, but also Chinese and French that have yet to be published. And the questionnaire is available at this website. It's been translated in probably about 12 languages, but these are the ones that are up so far. The most recent one is Hebrew, which was a lot of fun helping to translate, so that will be up as well soon. So I hope that what you've understood is that you do have a lot of skills to work with this population, and I think that's all.
Thank you so much, Georgia. Lots to add to our clinical assessments now. Thank you. Our last speaker for the morning is Dr. Adrienne Hancock. Dr. Hancock's Associate Professor at the George Washington University in Washington, D.C. Her primary research areas address transgender voice and communication, including psychosocial impacts, speech and language characteristics related to the perception of gender, and treatment efficacy. And aside from her many publications and presentations on transgender voice, Dr. Hancock has won a teaching award, the Bender Teaching Award, so congratulations, and serves as teaching and learning coordinator for her department. So she is invited today to talk about current perspectives and future directions for transgender voice care, and I hope that this will stimulate lots of ideas and questions for the panel discussion that follows. So, Adrienne.
Thank you, Nancy. Well, you have had some excellent talks on what we know at the moment, our current perspectives. I will hope to elaborate a little bit more on those and some of the more emerging areas of research that might direct our next steps. In terms of effective target options, we've learned from Jenny to select wisely, although the research is limited in those areas. And our assessment needs to be appropriate not only clinically, which many of you in this room probably already know how to assess a voice, but culturally, so using the TVQ instead of the VHI and things like that. Asking about gender positioning that you wouldn't do. But a lot of what you would do is not very different from someone who doesn't identify as a gender other than what they were assigned at birth. I want to just highlight one of the articles that Jenny did mention. This is the full citation. It is the most recent and quite comprehensive document that we have. It's the companion document to the standards of care that WPATH has presented. So if you miss or don't remember something we talked about this morning, check here. And I'll try to go a little bit beyond that. You've seen some of the specifics, so let's zoom out and talk more about the whole landscape. What about evidence of effectiveness? Gender diversity. We've heard several times that we're mostly talking about trans women. Well, important and special, but there are other populations to consider. And then I'm recently become interested in access to services. Let's be optimistic and say we all get good at doing this. Do people want to come? Oh, but we actually don't know. So I've been looking into that. So the current state of evidence. You're a clinical scientist, so I hope you have a healthy dose of skepticism. I recently got a gift from a student that inside the folder says, "Show me the data." And I feel like that's one of the best gifts that anyone ever gave me. Thank you, Sierra, because I say that all the time, and I ask my students to continue to say that. So I want to talk to you a little bit about the levels of evidence for feminizing voice treatment. Okay. So this is the highest level, experimental randomized control studies, down to control studies, studies without necessarily a control group, and then of course expert opinions, but not a lot of data. No experimental studies have been done. Oh, by the way, this is what Jenny mentioned about the not a systematic review, but a comprehensive search, and an update later in the SIG3 newsletter. We do have 3 studies that are considered quasi-experimental, so these would be some to look at. 2 of them were very recent, and also 2 of these 3 were in the Journal of Voice, so I'm glad we're promoting the science of this treatment in our journal. Only a couple more observational. These were cohort studies, so a little larger, but no control group. And then, of course, there's lots of experts that have opinions. But let's try to get those levels of evidence a little bit higher. In terms of the outcomes in these studies, a lot of times it was just, does the pitch increase? But I'd like to ask more measures. First of all, my little pet peeve is use semitones when you're reporting change, particularly when moving across the scale, so that these studies can be comparable. Also, listener and self-perceptions. Recently, Sarah Poole, a student of mine, published her thesis in Journal of Language and Social Psychology that showed listeners who identify as straight rate trans women as somewhat less feminine than their non-straight counterparts do. So perhaps we need to be describing the listeners in those studies we use as well. We also want to talk about who actually benefited from those treatment studies. We haven't talked a lot about the trans women who come with nodules, or our trans women in the clinic now who also has vocal paralysis. So those cases need to be addressed. Singers, trans singers mentioned, they're working on a PhD in that. So we need to look at a broader spectrum of cases from a vocal perspective. And also, we're looking at people who are already coming to clinics, so they must have the desire and the means to access services. We also don't have a lot of studies comparing types of treatments. For instance, does our therapy or intervention that we do have better outcomes than intervention that someone might get off of YouTube? Hope so. If someone wants to do that study, it would be great. Okay. So just to sort of summarize where we are, currently people can sound more feminine. They can improve satisfaction with their voice. I'm comfortable saying that. But we do need to have higher level research designs and look at those sort of messy cases, not just the ones that we control, to have good outcomes that are reportable. Okay, let's talk about gender diversity. First of all, trans men's response to testosterone. I recently conducted a study with Michael Irwig and Kayla Childs in response to testosterone. Here's one man's outcomes from that study. You can see here is mean fundamental frequency, and then we had 2 measures before taking testosterone, and then measured several parameters of his voice, but here I'm just presenting the mean FO during breeding. So I've sort of highlighted a gender-neutral zone that some literature suggests, and then typically, of course, males are down near 100, females are around 200. Pretty stable baseline. Where do you suppose that data is going to go? Visualize it. Ready? So our assumption that, oh, when you take testosterone, your voice is fine, does not seem to pan out. Well, we didn't just test one person, we tested 7. So let's put this first participant up in the corner there. So this is the same graph, I just need you to see the difference in the patterns. So 2 other men, again, pretty stable baselines, 3 months to 6 months went down and then leveled out. These 2 men, no change at 3 months after, but a big change 3 to 9 months, and then leveled out. So they also changed over a duration of 6 months, but there's a slight latent response to the testosterone. And finally, 2 other men had a pretty steady decrease in fundamental frequency over the 12 months. So out of just the first 7 men that walked into Dr. Erwig's office that were naive to testosterone, we have probably 4 or so different responses. And so our assumption that, oh, testosterone takes care of the trans men, we should be skeptical about that because the data actually doesn't show that. Fortunately, David Azul has recently published systematic reviews of transmasculine, as they're called in these papers, vocal situations and vocal functions. I'll differentiate those quickly. Vocal situation includes their anatomy and physiology, their acoustic properties, how they're perceived by others, what other gender attributions they get, and also the culture and situational context in which this communication exchanges happen. Whereas vocal function is basically vocal ability, and the vocal function parameters are what we would measure with anyone, regardless of their gender positioning. So you'll notice these levels are the same as what I showed you before in the trans feminine literature. About 32 studies, so about the same amount, except that 29 of these were about testosterone. Only 1 of these, and it's an observational case study, N of 1, is about voice therapy, and 2 of them are about voice surgery to actually lower the pitch or the fundamental frequency. Vocal function is also about 24 papers. Again, there's some overlap, some papers report both, some didn't. So their level of evidence in the transmasculine literature is also very low levels and also heavily weighted towards the testosterone effects. And we don't know much about sort of voice behavioral interventions for transmasculine people. I want to just show you quickly a table from the voice function article. These are the measures he used for voice function. If the paper talked about voice quality, pitch range and variability, vocal control, stability, vocal power, vocal endurance. Of course, these would be important to trans male singers. There were 14 of the primary research studies. Again, some of them were very low sample sizes, and then 10 expert papers. So he reports the percentage of those that did have restrictions in this area. Okay, so you're expecting what? You expect the trans men to have high reported restriction or low reported restriction? As if you've worked with them before, right? There's actually a pretty high percentage of reported restrictions to voice function. So testosterone does not solve everything. It often decreases pitch. We do not know to what extent, and we cannot predict what pace it does so at. And actually, if we're going to be on one side of the fence or other, there's a lot of evidence here to say that they might actually have problematic situations if they really need things like voice quality and control. So again, particularly for professional voice users. Gender nonconforming, just to be clear, these are, I'm using here, people who do not identify exclusively as male or female. So one article by, right now, Schultz or something, had 7 gender nonconforming, some said more male than female, rather male than female, neither male or female, both male, female, and then one no gender. So it's, again, just to reiterate what Georgia said, ask how they describe their own subjective gender positioning. Now, interestingly for us, in terms of what goals we want to set, they might not, okay, probably wouldn't by definition, desire to have an unambiguous male or masculine gender presentation or gender attribution by others. There's not much literature on this. A paper in, again, the newsletter, Ashley newsletter, Special Interest Division 3, 2 years ago, devoted a few articles to this, and David Azul gave some recommendations. Ask about subjective gender positioning, vocal function, how is that voice working for you now? What their own individual goals are. So this can be a very client-centered approach. And he cautioned that it's important to explain the treatment limitations and the fact that we don't know much about what voice therapy does for people who are not sort of using the same voice all of the time. For instance, we know for trans women, we generally, well, I shouldn't say we know, we recommend that trans women, the prognosis is better if you're constantly using that female voice in your female role, as opposed to maybe you're not out at work yet, so you're presenting in a male role and using a male voice at work, but then everywhere else you use your female. It's going to be a little bit more difficult to habituate the behavior. So with gender nonconforming, who typically are more fluid in their presentations, that also might be a limitation, but we really don't know. And he also says to try behavioral voice interventions first before something like surgery or hormones that would be more permanent. Some people take maybe a little bit of testosterone hoping for a little bit of an effect, but we really don't know if that works. Also, I just want to remind you, we're talking a lot about clients' gender identity, but clients are not only their gender identity. We have many facets to our identity. If I just said, I'm a cisgender woman, you still don't know a lot about me. So don't forget that this all varies according to not only their gender positioning, but their age. So we have a lot more discussion among clinicians about younger people coming. What do we do with an adolescent? I've never had an adolescent. Or in our clinic, we tend to have a lot of people who are retiring. And they said, I never wanted to come out at work, or now that my kids have gone off to college, I feel more free to come out. And so they're later in life transitions. And those might be treated very differently. Also looking at the effects of their ethnicity, race, cultural circles they're in, lots of things to look at. So just a little side note here to remember to describe a lot of aspects about their identity in your case information that you're taking, but also as you begin to report research, these are important aspects to include start comparing studies. So to sum up the second area of current perspectives and future directions, I had a very negative way of looking at the current status, but I tried to be half full, glass half full here. Some transmasculine and gender nonconforming people could benefit from our services. We really need to understand these populations better. I would really like to see us using the plural S on populations, understanding that to just say a trans person is very vague. We need to explore the implications of that diversity and move towards even more. I think we have made progress, but even more towards a client-centered care model. And we need to identify and remedy the problematic voice situations. So remembering that whether a person's voice is perceived as a gender that they're comfortable with and want to be perceived at, we also have to look at, is the voice functional? Do they have endurance for doing their public presentations they might do, or being a teacher, whatever it is. So whatever is problematic for them, that we address that, whether it has to do with their gender presentation or not. Finally, this area is very emerging, access and barriers to service. There's several models in the literature to look at sort of healthcare access. I will use the Levesque model because I like it, the direction. I know this is a little small to see. But basically, it begins with a person who has healthcare needs. They need to perceive that need and have a desire for care, which I think is very relevant for this discussion, because just because a person is transgender and just because they sound male doesn't mean that they want services or want to begin to sound female. So not everyone will be on this path to access. But if they are on the path, do they know where to look? So this is healthcare seeking. Do they actually reach it? Everything from, can they afford the transportation to get there? Is it available in their city? Things like telepractice might be relevant if there are very few people who are competent to provide this service. Do they use it? So things like adherence or compliance or no dropout rates. And then finally, at the end of all of those, is healthcare consequences. So are they actually engaged in benefiting from whatever intervention they received, whether it's surgery or behavioral voice therapy or hormones? I like the Levesque model because they provide a lot of barriers, possible barriers, and they do it not only from the provider side, but the population side as well. So I'm not going to go into all of the details, but for example, the first barrier that might come, if you go from the provider's responsibility, is approachability. So do the providers accept that trans people could benefit from voice therapy? As opposed to the sort of the population side, which is, do they have the ability to perceive? So, for instance, they have to know what a voice, speech language pathologist or a voice teacher is, and that they actually do have skills that might be beneficial to changing their voice and communication presentation. This is a little bit like health literacy or financial literacy, and you just have to even know it exists in order to learn about it. And so, of course, problems at any of these can create barriers towards moving towards that healthcare consequence or outcome. So let's look first at the provider's side. Ask yourself, either of your own self or perhaps of your profession discipline, are you approachable, accepting, available, affordable? Those of us in America, this is often not covered by insurance. Are you appropriate? And I'm going to tweak Levesque's model to say that means competent to serve, both clinically and culturally competent to serve this population. Well, recently Kelly and Robinson did a survey of SLP and audiology patients. This is 190-something adults who had received services. This is not specific to voice services, and it's not even specific to trans. These were LGBT participants, as they identified. But I think it's still an important takeaway, so I decided to put it in anyway. Of these 190-something patients, the majority perceived a heteronormative bias by their clinician. So an example of that might be when you're taking your case history and you say, okay, what does your wife feel about that? And just because a male is sitting there with a wedding ring on, you have presumed that he has a wife as opposed to a husband or partner. So something as subtle as that. On your intake forms, it has name, birth date, gender. Does it have a checkbox, male, female? Or is there a line that they can fill in their own? That's an example of this heteronormative bias that we really have to ask ourselves about. And I, in this past year, 2 years really, doing this work with some students in some journal clubs and focus groups, have learned a lot about subtle forms of bias that I wasn't even aware of doing. The other interesting finding here is that even though a majority of those clients consider disclosure to be important, a minority actually did disclose. So they are experiencing some sort of apprehension or fear towards disclosing their LGBT identity. Another survey study of 290-something SLPs found the good news is overall positive. They're willing to learn more, but they admit their willingness or comfort with the LGBTQ population was greater than their actual knowledge of it, particularly the trans population. And they had a very limited knowledge of transgender communication services. And by very limited, I mean when we asked them what is typically included in communication feminization therapy, this is an open-ended question. I think we did say, if you don't know, feel free to leave it blank. Guess how many left it blank? Half of the people we surveyed, and this is a self-select bias in a survey, right, internet survey, but half of them left it blank. Even the people who did fill something in, 81% included pitch, and you notice that when Jenny mentioned the targets, pitch and resonance are really the only things we know for sure and need to work on. Don't really see something that describes resonance there. Tone, maybe less than 20% list. Not surprising, considering that we usually don't have it in our master's curriculum. 47% said they hadn't received it in their master's curriculum, so I implore those of you who teach a voice class to master's speech pathologists or any discipline that you're in, please include this at least as an assigned reading, even if you can't get them practicum experience, to be both culturally and clinically prepared to serve this population. All right, the other side of that model was the populations. Do they perceive the need? Can they seek it, reach it, afford it? And do they engage and actually achieve the desired outcome? 88 transgender people replied to a survey. Only 15 of those 88 even understood what an SLP can do for trans voice. I think only about 40 even knew what a speech-language pathologist was. When asked if an SLP could assist, about a little more than half said yes, even though only 4 of them had actually been for a gender-related service from a speech pathologist. Only 3 of them said they would like to go. So this gets to, even if we get good at it, then we shouldn't assume that everyone wants it. Here's a great quote. My understanding is that there aren't any speech-language pathologists for female to males, and also that good ones, which are trans-friendly, are hard to find. That's disappointing. Recently, my student Sierra Downs took a point role in this study to look at trans people of color, and is their experience similar to what Sawyer reported in the 88 trans clients. And basically, we had quite a good representation of different races, and one of the interesting things that came out of that was that when we coded the comments in the transcripts of the non-voice related interventions, such as hormones, gender affirmation surgery, even social support services, 88% of the comments were pretty accurate and informed. Whereas when they talked about what you could do for voice and communication, they were not only uninformed, there was a lot of misinformation. Things like tracheal shapes affecting voice and the testosterone, as we pointed out before. I'd like to read this quote from the focus group. It can also be a struggle when you're trying to come out of sex work and get a job. Because when you get a job presenting to the public, like when you're trying to get a job as a cashier, receptionist, or as a nurse's aide even, frontline stuff where you work in public, it can cause difficulty. And it's really sad. So I'm, again, going to try to be glass half full and say that, well, SLPs are learning, and they express willingness to learn, but also the populations don't know much about us or what we can do. And I'm willing to say that some might want to, even though all might not. Our next steps in this area, I believe, are communication or collaboration with the community to determine those barriers more specifically for each population and community, and to reduce and eliminate those barriers, which I suspect is really going to start at the beginning of that access model with educating providers and also educating populations. Hopefully those two will sort of keep up pace with each other. So in summary, we need to improve our evidence base with higher level study designs, actually comparing different types of treatments, or at least treatment delivery models. We need to consider more populations, and we need to reduce the barriers to care. Thank you very much.
Thank you for the food for thought. I'd like to invite Dr. Hembry, Dr. Sadalov, Dr. Oates, Ms. Dacakis, please come up and join Dr. Hancock and me on the podium here so we can get ready for our panel. While they're coming forward, I just want to make an announcement. It's not related to the specific topic, but there is a documentary, an award-winning documentary on voice and trauma that is playing on a loop at the Liberty Room, which is near the elevators on this floor, that was created by Elisa Monti, who's up here, so thank you. And take time, you know, when you're heading up the elevators to stop in and take a look at features and several members of the Voice Foundation in the documentary. So there's a flyer for it on the table if you're interested. Meanwhile, we've got our panelists up here, and I'll begin by posing a general question that I think is just kind of running through my head this whole morning, and see how you all want to respond, and also invite you to ask each other questions before we take questions from the floor. So the thought that keeps running through my head has to do with the psychological and emotional impact of what we do. We heard a lot of wonderful information today, a lot of competence and evidence, and I appreciate that. And I invited these particular speakers because they actually have evidence and they talk about evidence, and we need all of that. I'm not a clinician these days, but I do think a lot about when you get a patient in your office who's struggling with their own thinking about coming out and transitioning. How do you deal with everything you know, and also the emotional and psychological impact of what you do? Big question. Anybody?
Are you asking about the impact on the patient or the impact on us?
It is a two-way street, and I was thinking of the patient, but I'll take either.
PhD work very much looked at the impact around the impact of voice on life in general, everyday life. Interesting data.
Was the question about the impact of voice on everyday life, or the impact of our therapy on their emotional state?
You know, I can let you go whatever direction you want.
Well, I think there are a few things if we're looking at emotional. And the first thing is that you have to be very prepared to deal with, you're dealing with a vulnerable population, and you have to learn to deal with the emotions that come with that. So it's not unusual for us to have a client who will arrive in clinic who has been harassed on the tram on the way, and you have to just let their therapy session go. So you are dealing with emotion all the time because you're dealing with a vulnerable population. And if you're dealing with trans women who are coming to therapy because of their voice, they're often coming because their voice has attracted negative responses. That's one point. The other point is the impact of voice on their emotional and psychological well-being. We found through our research with the TVQ that the impact of voice on the individual changes with a couple of factors. The first factor is the length of time that they're presenting in their self-identified gender. And the other point that was interesting was that women who had, and I'll go now with my preference of just referring to these people as women, women who have had gender reassignment surgery do not report as frequent an impact of voice on their everyday lives as those who hadn't. Now, nothing magical happens to the larynx with gender reassignment surgery, but what happens is that, I think what happens is that it's to do with their gender identity and the consolidation of their gender identity, and that they feel more as the woman that they are because they're not having to deal with this other abhorrent aspect of their body. And therefore, their attitude and the impact of voice changes significantly. So they don't rely on voice as much to present their gender identity. They still have concerns about vocal functioning, but the impact is not the same. And at the end of the day, if someone abuses them, they can, and I don't want to be gross or crude or anything, but clients have said this, at the end of the day, if someone harasses them in the street, they know that they can just say, I'm a woman, you know. But definitely our research has shown that the psychological impact of voice changes with the passage of time in those two.
And I spoke to some trans individuals about coming perhaps to speak today, and and I'm sorry that we don't have someone on the panel, but many people don't want to talk about the journey. It seems to me it's been a really uncomfortable topic, and I think as clinicians, it's obvious that we, none of us are in the. Well, I don't know if it's obvious, but don't believe any of us are in the LGBT community. And I'm really sorry Lance Wallert isn't here because he is not trans, but in the LGBT community and a big advocate. And I think we need more people who really understand the community and are in the community to help. But the fact is there are not that many people on percentage, especially trained in our fields. And here we are presenting as cisgender and white usually, and you've got these clients coming in and trying to help them or relate to them. I don't know how much of a difference it makes, but I'd like to encourage more people to get trained to do the services.
That might be a heteronormative assumption.
It wasn't, that was a second, it's funny, I almost didn't say, because I'm not outing anybody as cisgender here, because it's possible. And there may be other members of the community here, I don't know. I just know Lance is openly an advocate for the gay community, and I wish he was here, so I'm sorry for that.
This is one really good reason why those of us working in this field need to join organisations like WPATH and our local organisations. USCATH is now up and active. Going to their conferences is a terrific way to increase your cultural competence, but get to know a really broad variety of people with such different gender perspectives and positions. It's terrific.
So yes, I don't know if you wanted to comment, Bob, on the emotional impact of the clinician. I had a feeling.
Actually, I wanted to reflect on the perspective on how we look at this community, because trans is special, trans is volatile, so are the rest of our patients. So I think we need to guard against looking at this population as a different, more emotional, more volatile population, because I think that if we approach them that way, in some ways we do them a disservice. Most of my practice is taking care of singers who are similarly volatile, really similarly fragile. We joke about practicing psycholaryngology every day. And I think that we need to approach all of our patients considering the emotional impact of their particular voice problems, and we need to approach our transgender patients in the same way. And if we single them out and treat them differently as providers, I think that it's a disservice.
Excellent point, thank you.
So can I make one quick comment about the emotional impact on the clinician?
Please.
I started a group a couple of years ago to support private practitioners in working in this area. And at our last meeting, one of them said, can we work out something to support us clinicians, because sometimes I can't cope with it, because my days are like watching a sad TV show all day. And while we don't need to make them special, there are some very, very sad stories, and it does have an emotional impact on the clinicians. They have to be prepared and have support to deal with it.
As clinicians, to some degree, we gravitate to patients whom we like. Within the otolaryngology world, the personalities of those of us who take care of voice patients, or take care of ear patients, or take care of cosmetic surgery patients are very different from those who specialize in head and neck cancer. The emotional gratification for physicians who are capable of communicating and emoting at all comes from helping people. Trans people have problems. We can make them better. Singers have problems. People with head and neck cancer have problems. There are people who are very happy dealing with high maintenance patients. Singers are high maintenance. Many of us have high maintenance friends and family, and we're accustomed to having dealt with high maintenance people, as opposed to the head and neck cancer guys who are working on their third pack at the VA. They're different populations, but the fundamental common thread is that we select people with whom we are emotionally in contact and take them from wherever we find them to better. So our emotional context is in some ways predetermined by our practice selections, which can be very challenging, and when they are, it's because we have chosen to work in those challenging settings.
How many of you work on a team where you include the psychologist or psychiatrist or social worker or, yeah, okay. Yeah, and I think that would just be critical, because we know how high the suicide rate is amongst these adolescents especially.
I wanted to comment on that from one of George's comments, because my reaction when you were talking about not doing glissando into male voice because it created a disproportionate psychological reaction was just the opposite. We would continue to do that because if that psychological problem is there, we want to know about it and offer the opportunity of therapy and intervention to help put it into the person's life perspective. So I mean, your choice was perfectly reasonable, but the other choice also is reasonable, to unmask it rather than leave it hidden if it's that volatile.
That's fine.
Thank you so much.
I think, like the reaction that I think just the fact that, I agree with what you're saying, but the reaction can be very severe. Like, I had one client who literally said, wait, because she had already started making some changes to her voice. And she said, wait, do I have to go down there? Do I have to bring him back? Do I have to? It was really, I'm talking quite significant. And I'm not, yes, you're saying you need to deal with that and bring it into their life perspective, and yes, I agree with that, but I would still maybe not on my first assessment.
I put this on the same spectrum as dealing with any functional dysphonia patient. Every once in a while, the functional dysphonia is there for a psychological reason, and you treat the functional dysphonia and the patient decompensates psychologically.
Yeah, sure.
But we need to know that, we need to anticipate it and avoid it with psychological intervention ahead of time if we can. But I think it's part of what we do as voice care professionals. It's total care.
I think we've got some people lining up here, so...
Are there other questions? Well, before we do, is there anything else you all wanted to ask each other? We're okay, so we should go for the floor. Yes, please.
Hi, I'm Beth Falcone, and I'm a voice teacher, singing teacher for theater. And about 15 years ago, before any of this had anywhere in mainstream, I was at a theater school where a person came in and said that they identified as male. And of course I pride myself on those 5 A's best I can, and I'm, so approach all of that. I hope one day not to be affordable, but right now it's all 5. What was frustrating for me, and so I'm here to ask advice, should something like this occur again. They identified as male, so I said, okay, and yet I was dealing physiologically with a female voice. This person hadn't even gone through any kind of psychological assessment or anything yet. So this was just something that they said, I'm going to do. Still, I take it at face value and say, okay. And I gave this person, and forgive me if this is a terrible thing to do, but I'm doing the best I can with the little knowledge I had. I gave them something like from Peter Pan or something, and he got very angry. I'm not a boy, I'm a man. And yet, I'm a teacher in a situation where this person has to perform in a few months. What do? I am physiologically limited about what I can give this person. And I'm in a situation with the institution where they have to perform. It was so confusing, and there was no support of any kind. I'm glad to know that there are organizations for private clinicians now that we might even be able to ask someone now.
You don't know enough about the singing, but
We don't have anyone really from singing or theater world here, but that sounds like a situation where you do have to use some, I would say, use counseling skills rather than be a counselor. I think that is a very fine line to walk. But talk about the role you're going to give before you give it, maybe. And it's sort of, the only thing I can relate to is the expectation conversations that we sometimes have, where someone comes in, and I work at a university clinic, and so there's 18, 20-year-old clinicians, female, cisgender female, and I just want to have your voice, and I'm looking famous. But you're 60 years old, have lived 59 and a half of those years as a male, you're not going to have her voice. And so some of those conversations about adjusting expectations is probably where I would go in that situation, because it seemed to me that there was a problem with his expectation of what he could do versus your knowledge of what he could do, at least at that time. And so maybe fall back on some of those counseling skills about expectations, and that maybe the core of that problem was a mismatch between expectations and abilities.
I agree, but just a couple of things, not the least of which is to asking him what he wanted to sing, which he probably did. But there's an intrinsic bias implicit in your story, and that's a bias of what constitutes male voice. Alfred Deller and Michael Jackson had male voices. They may have been falsetto, but they were male voices. So if Locke, your natural reaction to accept the male stereotype and look at the breadth that's encompassed by male singing, then you can approach that person with lots to work with that might be physically compatible with his biological vocal apparatus and still identify it with male role models.
So much.
Thank you very much for the panel. I really appreciated the presentations and now the wisdom as it's shared in answering the questions. I do come from NIH, so I want to give a plug to the opportunities of funding right now related to work with LGBTQ individuals. NIH has a committee called the Sexual and Gender Minorities Research Coordinating Committee. It started as LGBTQ, but we have formed to be as open on our language as possible, because you could stop at LGBTQ and then add more. There is a funding opportunity targeted to research in this area. So anybody who wants to work in that space and Adrienne was funded by NIDCD. Just please contact the website, email us, talk to us, and take opportunity of this. Thank you.
And don't miss Lana's session on Saturday.
Tomorrow, yes. In fact, I'm going to add this. I wasn't planning on speaking, but as GM, but now I will add a couple of plugs to that too.
That is so good to hear. This has been an area of constant struggle for people working in this field, having difficulty accessing funding for research. The research that George and I have done and many other Australians has had to be done on very limited funding. Our National Health and Medical Research Council is not funding this area, and it's been extremely difficult for us. We do everything on a shoestring, so that is fabulous news.
Before I go, also, foreign applicants are eligible.
Could I make a comment that many of you may not be aware of, but should try to talk to people who are involved? There is an NIH-funded group called Transnet that, in fact, we had a meeting at the NIH this past year, and in which individuals from various dimensions of care for transgender individuals came to the meeting, discussed what were the prime areas of concern, what were the areas, and there were 3 or 4 institutes together at the meeting. I don't know when, for those of you who play games with the NIH, you know it's very difficult to get beyond one institute, and to have 3 or 4 joining together and giving you advice about how you could get research done. It was I suggest that you talk to individuals in cities where there are transgender and transnet people and see if you can join in there and give another dimension to the care that's available and will be funded by NIH.
Yeah, I have one comment for possible responses and then a question. I have become, in my work in motor learning, I've become convinced that perception drives production. And there's some really nice data to that effect as well. And recently I was working with a trans woman, and I had the flash of insight to ask her, when you think, what do you hear? Do you hear your female voice or do you hear your male voice? And she said, oh my God, I hear my male voice when I think, right? And so I asked her for the following week to do some silent reading every day and to hear that in her female voice. Because she had a sense of what that was. And she reported that to be incredibly helpful. So that's number one. And I've never seen discussion of that in any of the stuff that I've read in this literature. And a second question refers to a gender fluid person at my former university, the University of Pittsburgh, who believes that the trans population is more comfortable receiving this training from trans people or non-gender conforming people rather than from cisgender people, and I'd like to get your reactions or responses. And this person is doing a master's thesis on this very question.
And that was Kitty Vertolini Abbott and our last
University of Delaware.
University of Delaware. And our last
Yes.
speaker was Lana Sheckham, and if you all would introduce yourselves when you come to the mic.
I think it would be very helpful to have more clinicians who are gender nonconforming or even identifying a population that has similar background or experience. Just like I mentioned briefly those 2 focus groups, it was very important for us to find facilitators who were people of color and or in the LGBTQIA community. Because again, all of the people on the research team at that time for the focus group were white, cisgender, straight, middle class, all of that. So I think it's very important, and I would love to see one of these outcome data.
How do you feel? Is that a possible barrier for some individuals in seeking treatment?
Possibly. It didn't come up in the focus group, but I think it could possibly be because of those unconscious biases that everyone has.
It raises another issue that goes beyond laryngology. It's an important question, and it has what looks like an obvious answer, but it's got a flip side. It's the same question, Katie, as to whether you're more comfortable with a female gynecologist
Right.
or a female breast surgeon. My wife is a breast surgeon, and when she hires people, gender shouldn't, but is a factor. While we're living in that world, we also have to pay attention to educating the male physicians and the non-LGBTQ or trans physicians to have such good perspective, sensitivity, and to function so well that once those populations actually meet the physician once, it's no longer a problem.
Right.
The reason it's a problem is because in some cases it is a problem.
Yeah.
Okay, so it's not just finding more trans providers, it's educating people so that they're as comfortable with trans patients as they are with everybody else. And then that problem will go away, and we should be able, just on the basis of numbers, to succeed at that a lot faster than we will with populating the world with trans laryngologists and trans speech pathologists.
Well, I agree.
It's an important barrier.
It's also relevant. For example, I've had voice problems in the past. That's why I got into this field. I had nodules and surgery, the whole thing. And so I understand at a certain level my patients, especially my senior patients who are going through that. And that understanding is difficult to substitute with education or even exposure. So I think there's something to that argument.
I also don't want anyone who maybe doesn't know very much about the LGBT community yet to feel that it's a barrier for you to get into it. So I know everyone has biases who grew up even rooted often in religion. That should not be a barrier to doing this work. Realizing those biases and working on them is hard from the provider, sort of cisgender straight perspective as well. So don't feel like just because you don't know about it yet, it means that you'll never work with this population.
But you're right. There are certain things that people get from experience that give them a little extra that isn't necessary but is helpful. And the fact that I was a professional singer helped a lot in the early days.
Oh, yes.
There are lots of wonderful laryngologists who are not performers. There are things that I see that they don't because I'm a performer. It's why I make all my fellows take singing lessons. It helps, but it's not exclusionary.
I think that's a good way to frame it.
So I don't
Thank you.
know for this population what the analog of singing lessons would be, but we'll have to work on that.
Could I make just a very quick comment about Kitty's question about perception and the importance of the role of perception in voice change for people in this field? I think it's absolutely critical, but I don't think we know enough about its role yet. Georgia and I at the moment are involved in a collaborative study with speech pathologists from the Karolinska University Hospital. Our study is about the effectiveness of speech-language pathology interventions, but as part of that we're trying to look at a whole series of predictors of outcomes, and their perceptual skills, their musical skills and so on are going to be a significant part of this study. So
that's beautiful. I'll just say one more thing because there's a whole bunch of people that have great questions later. There was a study that really impressed me. It was a study on people who perform poorly under stress, golfers who perform poorly under stress versus those who perform well under stress. And it was found that there were brain differences, and there were also mental differences. Those who performed poorly were giving themselves biomechanical instructions about how to perform the task when they were under stress. Those who performed well under stress imagined had a perceptual image of the ball going into the hole. Okay? And I know that from singing too. You're singing along, and even when I'm singing mentally, I make the same mistakes as I do in real life. So I think part of the issue is you have a brief forward copy of what you're going to sound like before you speak. And I think that feed forward copy of what you're going to sound like is profoundly important. So anyway, I agree all of this.
Yes, sir. Let's move on to the next question.
Yes, this is for Dr. Henry. As you were talking, I know I just read yesterday of a couple, a male and his partner is a female transcending to a male, already undergone hormonal therapy but not surgery, and they elected to have a child. And I wondered if you could speak to the fact of someone, a female going to male who still has the anatomy and wants to have a child while they're undergoing hormone therapy. What are your concerns in that regard?
I think that the concerns are that you are dealing with the people who are giving the hormones initially and maybe therefore urging someone to take a holiday from their hormones that they have, making sure that they have the appropriate psychological support for these individuals so that once they have to indeed utilize the female reproductive function and no longer indeed have the outward look of the sex which they feel is their appropriate, is consistent with their appropriate gender, to have them go together and not just go to an ordinary gynecologist or to someone who is really not familiar with the pros and cons of care and various psychological aspects of it for the trans population. It's extremely important that these things can be done. And in Europe, there are a number of clinics that indeed are now receiving, and with government-funded care, are receiving individuals who are trans men, who would like to have children, and the care that they have to go through. I think that I don't have any of my own patients who went through that because it's not as common an event that occurs in the United States as it does in Europe. But I think that physiologically, endocrinologically, it's certainly appropriate to do, but hopefully, like anyone else who is going to be a father or a mother, that indeed the psychological component of the changes that are going to go on with them and the changes that they need to make in order to achieve parenthood are well known, and that they can indeed take the psychological aspects of it as firmly and as safely as they could if they were not indeed somebody with gender dysphoria or a transgender person.
No, I once did a paper on pregnant voice. Maybe my two research worlds will collide.
I think, yeah.
We've got a collaborator here and have funding.
I think those of us who take care of transgender individuals, I think, need a lot more in the care which we don't often have time to get, in the dimensions of psychological care that are important. We very often brush them off to a psychologist who is interested in doing that, or someone who has been interested in, but they also don't know how to take care of people in the midst of reproductive care. And being an andrologist, someone who saw lots of men in my career who did not have enough testosterone or appropriate testes to be able to make sperm and therefore have children, and to make decisions that they, as a person and as a couple, had to go through, is that there are a lot of psychological dimensions of it that if you don't help the person with those as well as the physical dimensions, then you come out with a failure for the patient. So that I think it's very complicated to tell someone who indeed has lived in a body that for them is appropriate, and at being a transgender man, but indeed if they have not had any surgery and know that they can in fact, under appropriate conditions of changes of the hormones, be able to have a child. To go through that is that it needs more, I think, than just an ordinary endocrinologist, but somebody who will help them, a gynecologist who understands the dimensions of the psyche of a transgender person, as well as the endocrinologists who are dealing with them. It's a complex area, but something that there's no reason why it should not happen more frequently in this country.
Okay, we'll stay on this side because this line filled up first, so. Yes.
Thea Peterson from Australia. I'd like to ask Dr. Sabloff about his post-operative care for these patients with your surgery. So what is the protocol after the operation in terms of voice rest? Because in Korea they're injecting Botox post-operatively and having a prolonged period of voice rest. and I wanted about your views on that.
Are you talking about webbing or?
Yes,
Okay.
anterior, yeah.
Because after the framework surgery, I usually keep people on voice rest for 24 hours, re-examine them, and if they have no hemorrhage, let them talk. That's the same as for thyroplasty. For framework surgery, I trust my stitches, so I keep them silent for a week, and then my speech language pathologists bring them gently off voice rest after I've visualized their larynges to make sure that everything's intact. And they begin speaking after they've said "ee" in front of me. They begin speaking with a voice therapist and have limited voice use that increases gradually. If they have allergies, we try and treat them ahead of time. If they have an allergic season, we try not to operate during their worst few weeks so they're not coughing and sniffing in hard and doing other things that will tear the repair. But generally, I keep them quiet for a week, and I'm not really sure that that's necessary, to be perfectly honest. There's certainly no evidence to support it for most procedures, but for this for sure. But for no defensible reason, I keep them silent for a week and then bring them off and give them gradual return to voice use, mostly to minimize stress on the suture line until it's solid, which takes about 6 weeks.
Thank you.
Dr. Sadler, what is your opinion about the use? This does happen very frequently with our patients who go to Korea for surgery, that Botox is used. Do you have an opinion about the use of Botox?
I don't think that it does any harm, except that it causes dysphonia that lasts for a little while.
Exactly.
So that can be a little discouraging for people. In addition to which, I have to say that I think people put Botox in the wrong place. What you're trying to, if you're going to use Botox at all, you're trying to prevent forceful abduction, which will pull the repair apart. So if you put Botox in the thyroarytenoid muscle, it doesn't really accomplish much. You can certainly squeeze the larynx together despite that. So if you're going to do it at all, I would do low-dose Botox in both PCAs. But if you get enough to really solve the problem, then you have to do a trach at the same time. So I just don't find it worth the price you have to pay. And I certainly don't find any sense in putting it in the adductors.
No. Good. Thank you.
I'd like to actually follow up with a surgical question. I'm not a surgeon, but there was a evidence-based review in Journal of Voice in 2016 by Van Dam et al. That concluded, based on their review of the literature, that the web is not is to be maybe done with caution because there were issues about vocal quality, and that maybe it's not the best procedure. Comments?
Sure. First of all, know that concurrence of the editor is not a criterion for publication in the Journal of Voice. Second, that paper was a review of sorts that looked at all of the available studies, and its important conclusion was there aren't any really good studies available. That I agree with. The observation that they made, although I don't agree with their conclusion, the observation that they made is correct. If you operate on the vocal folds themselves and suture them together, your likelihood of having some dysphonia, either temporary or permanent, is far greater than if you don't touch the vocal fold edges and just operate on the frameworks. However, so are your potential for good results. So basically, this was another one of those review studies that the reviewers liked and we published because it was a reasonably good collection of available papers on the topic of transgender voice surgery. But you have to read all of those papers, even the really good scholarly reviews and especially the meta-analyses, with a very careful eye. The meta-analyses, which just because it's a meta-analysis has some credibility. It doesn't really. What it does is apply a statistical method to a lot of bad papers. The meta-analysis is no better than the papers included in the meta-analysis. The same is true when you're looking through papers and you say, here are a bunch of papers on focal fold webbing, none of them was very good, none of them had controls, and we conclude that webbing is not a good idea. That's not supported evidence. So thank you for asking that question. I think if you want to see what's been written on the topic, that's a good paper, but I don't think you can draw conclusions once you have concluded that there are no papers good enough to draw conclusions from.
Thank you. I believe we're still on this side for another few people. Yes, question.
Christy Block, voice clinician, trans voice clinician in private practice in New York. You just answered the questions I had about surgery. Thank you. I just want to thank you, Nancy, for putting this together. It's great to see all these important people in the front here, and there are more and more talks about trans voice, and it's really heartening. I had the privilege to talk to a number of people in the room so far, and there are at least 3 generations of trans voice clinicians in the room, and some of the younger generation are out as trans, and I'm very happy to have them a part of our attendees here. I'm a cisgender, cis-identified clinician. I have not had trouble serving my patients. I feel that I need, as a cisgender person, to have good clinical and cultural competence, and we would expect the same for trans-identified people as well. I also want to mention how I appreciate there are moments of clarity about transmasculine voice, one of my soapboxes. I'm so glad that it was spoken about more than usual. A big thank you to Adrienne for really spending a lot of time on it. And I think that access is a really big problem for those clients.
Yes, thank you.
A word about androgens and voice. We should all recognize that when we give people male hormones and pitch lowers, other things happen. I would love to see the age correlations on some of your data, because I haven't seen good research. Maybe I just missed it. But I would suspect that in the substantially older population, over 60s, that the androgen effects might be less. Because one of the things we're doing is causing laryngeal growth, as you do with the male hormone burst at the time of puberty. So we don't expect the pitch to drop and everything to stay the same, any more than we do when a boy's voice changes. So when people use androgenic hormones to modify vocal pitch, we should be counseling them that they're going to require therapy. They have structural laryngeal changes. They're going to have maybe some voice breaks. They're going to have some huskiness. It's reparable by retraining, but it's an expected part of the process. I mean, when you have a boy go through puberty, you don't expect him to go from a normal soprano voice to a completely normal, clear baritone voice without practice and intervention and evolution. And this is the same. This is not rocket science. Do you concur with your experience?
Actually, I was wondering if Dr. Hembry would talk about the new standards that are coming out. Is there any insight into the response to voice to testosterone, or are we still just sticking to fundamental frequency in the guidelines?
Actually, we have mentioned in the guideline and given a reference, and I don't remember the reference, I'm sorry, that will be used and have basically made the statement that the safety of androgens should be applied as it is to a long history that we have in the field of endocrinology of giving androgens to those who don't make it on their own and all of the adverse effects that may go on with that. As you know, the literature is not very good about what we might call safety to the voice or difference to the voice, because this is not a primary reason in which most endocrinologists give testosterone. However, that certainly is brought up, and patients of mine throughout the time had asked what it in fact would do to their voice if they were given androgens. And what I've done is to refer them to people in your field who know a lot more about what the outcomes and what the adverse effects could be. Certainly, it's one of the things that we would recommend is that the data are very clear in terms of people that go onto androgens late in life when they're 18 or in their 20s, they've never been, and even today there's still people that have androgen deficiency that don't get them, and to be very careful about what the adverse effects would have. But in general, we don't warn them that there may be adverse effects on the voice, and for doing that, and only if they have indeed noted some adverse effects for reasons that we didn't clearly, we would refer them on to people like you to be able to protect them, but they would stay all in the hormone levels within the normal range, and the frequency of severe abnormalities to the voice are very, very low.
This is an issue we've dealt with for decades with our endocrine and gynecological colleagues, with the use of medicines that are now given for postmenopausal libido issues, with anabolic steroids, and with older medicines like Dacakis that used to be given for endometriosis, yes, which if you give them to people making their living singing Queen of the Night at the Med, you end up in court. And it's an issue. We should also acknowledge a paper. Is Jean Abibal still in the audience? Yes. There was a seminal paper that Jean gave maybe 1987 or thereabouts, where he put up slides of smears of laryngeal mucosa and vaginal mucosa throughout the menstrual cycle and did estrogen stains. And these were the days when we used projectors, and they were dual projection. And you could not tell whether you were looking at vaginal mucosa or laryngeal mucosa. It went through an absolutely identical estrogen cycle change. And this was one of the first bits of evidence we had presented at Voice Foundation meeting that the larynx is a hormonal target organ.
I'm going to move us on because we have only 10 minutes left.
Can I make one quick comment there? I think when we're looking at effects of androgens on voice, particularly in this population, we tend to focus too much on fundamental frequency, that there are potentially some changes that occur into the resonators as well that we need to keep in mind. For some trans men in particular, the mismatch between the resonance functions of their voice and the fundamental frequency causes significant problems. Others, no problems whatsoever, but it's not just fundamental that is altering. A colleague of ours in Stockholm, Ulrika Nygren, has done some very careful MRI studies showing that there in fact are some changes to the resonators, not just to fundamental frequency, in people who are on androgens for various different reasons. And that's, I think, very important for us to consider.
Sally, let's go this side now.
Just put the microphone apart. One is a question and one is actually an observation. My observation is that working with trans women, I've had 3 clients, and I don't have a huge business, that were pubophonia. So they had a mutational falsetto, never really developed a male voice, which goes along with this critical puberty point that you were talking about, Dr. Henry. But I didn't know whether that's something that other people have seen. They're challenging to work with because they're in a falsetto, with a lot of voice cracking. So it's almost like you have to develop their male voice or a chest voice before you can take them then to a feminine voice. So that was my observation.
You need a laryngological examination before you can answer that question. There are two populations. There's the functional puberphonia, where they actually have normal laryngeal growth and speak in falsetto. And there is rarely failure of laryngeal growth. You can look and you see a pediatric larynx. It's small, it has an epiglottis that partially covers, and that voice is appropriate for that larynx. So the first thing you do when you get one of those patients is get a diagnosis.
Right. And we do that. Yeah. So yes, so I think that that's a really great point. My other, I was taken back by Dr. Cooper's comment that 25% of individuals who identify as gender dysphoria pre-puberty actually go on post-puberty and continue with that identification. So I just wondered, how does that affect your treatment as far as hormonal treatment, surgical recommendations, not being able to predict what, who will be that 25%?
Well, we are learning more so from the mental health professionals just what are some of the predictors as we look at individuals who are approaching puberty but have not yet approached puberty. And as you may know, in the United States, the variability of the onset of puberty is much greater than it is in general in the European population. Why that is, we're not certain. But so that in this country, we have a little bit more difficulty in knowing when people are approaching puberty, and the measurement of the hormones that would suggest that they're starting to make estrogens or they're starting to make testosterone. Seeing whether the testes are beginning to grow and they're beginning to get changes in pubic hair and other things are things that you can see as an indicator that puberty is going forward. I think that those individuals who have been followed by a mental health professional and the diagnosis of gender dysphoria is one that is very clear and that indeed is not waxing and waning in terms of the specifics of it. We're a little bit more concerned about these individuals than we are in somebody who presented as a patient that I gave you at a very early age and was very clear what sex they indeed knew that they should be. And those individuals are in the 25% who persist with their gender dysphoria for the most part. There have been some papers written in the European literature that indicate some differences that one can see in those that probably will desist as they go through puberty. Unfortunately, we don't have a great deal of precision about that as clinicians, and certainly not as endocrinologists who would know when that was going on, and that's why it's critically important, and we've recommended in several areas in the guideline that even in early before puberty, that mental health professionals indeed be involved in that to be able to see what's going on with the individuals and whether they show signs of desistance or they are amongst a group of individuals who in fact are likely to desist. That's why we wait into puberty, because most of the data that have been published indeed show that the signs of desistance are there probably within the first or second stage of puberty, and by the second stage of puberty, if they're going to desist, you know that. But that leaves a little bit of awkwardness, and for those individuals who have been seeing professionals and been looking forward to going through puberty and then having their puberty blocked as to what to do. There certainly is no harm in blocking puberty for an individual. And what the data from Europe, for the most part, show that those individuals who have what we would clearly define as gender dysphoria and have puberty blocked Indeed, the gender dysphoria does not go away in those individuals even up till age 16, and when they might start in having sex steroids. But there's a lot more, and they've published a couple of papers of groups of individuals whose gender dysphoria became much less well defined, and they were fairly highly predictive of their gender dysphoria going away spontaneously, and that indeed this is not somebody who that they would change their sex steroid environment.
We have time for maybe 3 more questions, and you've been waiting so patiently the whole time. Please.
I'll make a brief comment just to provoke your thinking. James Thomas, I'm a surgeon, a physician, and I just do laryngology. I've been taking care of mostly gender male to female individuals, and I like to think of speech therapy and the various surgeries as tools, and I don't think of them linearly. And that is that when I speak with a patient, I get a sense of what they want to accomplish. And so I would do surgery immediately on someone who is not very fluid with their voice and also doesn't want to spend the time on therapy. Or someone who doesn't want to take much risk would choose therapy first, and because then it's more time and effort on their part, but almost zero risk. And the reason I come to that conclusion is when surgery is successful, the patient no longer lives as a trans individual. They are a woman, and they no longer go to trans meetings, they don't see physicians, they don't see therapists. So that's how it's just a way of thinking about it.
Thank you.
Oh, and I'll present the results of surgery on Sunday.
Oh, okay, Sunday, there we go. Thank you. Well, we'll move on then. You go ahead, I think you're standing for longer.
Hello. My name is Kevin Dorman. I'm a non-binary speech therapist from North Carolina. So thank you all for having this day. This has been fantastic. I had a quick question. A large component about the presentations this morning have involved cultural competency on the SLP's half or clinicians' half, as well as a lack of awareness or perhaps correct knowledge about trans voice training amongst the trans and gender nonconforming community. I've been struggling with how to reach the trans community because one of the only places that trans folks seem to gather is support groups. And it is very much so a cultural no-no to invade those safe spaces, especially for the purposes of self-promotion. So my question is, what are culturally sensitive ways that you've found to engage with the trans community without invading these safe spaces and learn more?
I think it's very important to be invited.
Yes.
For sure. Particularly as a cisgender person. And I also think it's important to be clear about what you're going to be providing. So, for instance, as a follow-up to those 2 focus groups, we're going to hold a sort of a workshop, if you will, for the people that went to the focus group and anyone else, because at the focus group, they learned about it. And so we want to be really clear, I think, in any social justice work, not to be the people who come in, help those poor people, and then leave feeling good about ourselves, right? So I think it's important to do a couple things. Be invited, first of all, which means forming relationships and cultivating relationships, and also to have follow-up and be clear about what we're going to accomplish. So you're not going to come to a 2-hour workshop and leave sounding like a woman. We're going to come and educate you about some resources. I also don't want to go and show up and say, yes, speech therapy could do all of this. Come on down to our clinic. It's only $50 an hour. When then financial is the next barrier that we're going to run into. So I think it's important to just bite off enough that you can chew and to do that gradually. And it's probably going to be a slow process. And we'll probably learn a lot along the way, but I think it's important for all of us, whether we are in the community or not, identifying as part of the community, that we are very mindful about how we're received and what we're trying to do, and very grateful for an opportunity to help, and be really clear about that.
Yeah, we have time for one more comment. You can fight it out, but I was heading that way.
Susanna Cutrin from San Francisco. I was wondering if Dr. Hancock and Dr. Saloff could speak to this, although I welcome all of your thoughts. Thank you so much for all of the presentations. In regards to insurance coverage and cost being large barriers, is there a pathway for SLPs to provide service without laryngeal imaging in a case where there's no complaint of fatigue or endurance issues? And are there, excuse me, are there rules for non-SLP voice professionals, of which we have many in the room? And what do you see as like a pathway on both those tracks?
First of all, the George Washington Voice Center, same policy as Georgia described, which is we come in and do evaluation, and if we don't suspect an underlying voice disorder, we do not refer them to laryngeal imaging, the cost barriers, because we don't have a scope in our clinic. The WPATH standards of care are aligned with that. It says we don't need it. Although we have taken, we have referred clients, because we do have clients with voice disorders. 2 years ago, Sheila Sager and I presented some research on 12 trans women, and actually I was sure we would find some real hyperfunctional voice use there, but we really didn't in those 12. For better or for worse, we're still working on getting that published. But so I'm not too concerned about that laryngeal imaging, which is good for their access, speech pathologists or non-speech pathologists access. I think the cultural and clinical competence that we talk about can be achieved by non-speech language pathologists. I'm a little worried about the YouTube people, but I don't put singing teachers in that camp at all.
And we have a slightly different approach. Our speech pathologists.
Quick comment that I meant to make before, I'm sorry, but I think it's extremely important. It would be helpful to all of us who are endocrinologists and involved, especially pediatric endocrinologists. Informed consent and reproduction are two variables. It's the majority, probably, in the next 5 to 10 years of people that come into the field as transgender and will be getting treated will be younger individuals, those in younger puberty. And being able to get and making sure that there is good informed consent. Families obviously are involved in the informed consent, and the issues of reproduction that need to be told to individuals before they jump into hormones or any other kind of thing that's done must be. So I would ask all of you to hold us to and to become more comfortable yourself in getting informed consent and talking about reproduction to your patients.
That's always excellent advice. And to get back to your final question, our speech-language pathologists and singing voice specialists never work with anybody without a laryngeal examination first, for several reasons. Number one, you can't always hear pathology. Number two, if you treat people for a while and then discover pathology, you caused it unless your defense attorney can prove otherwise, which he or she usually cannot. We've seen people whom we thought had perfectly normal voices who had nodules that we couldn't hear. We've seen people with unilateral vocal fold paralysis that we hadn't recognized. We don't make it terribly expensive. It takes very little time. We're not comfortable treating without doing a physical examination first. I'm not saying that the other way doesn't have merit as well, but the only reason to not do a physical examination is financial, and that is not a good enough reason in our hands.
You weigh the benefits and costs, and for some of our populations, it's a really big cost. And I would say if you can't hear the nodule, if it's not causing vocal fatigue, if it's not problematic in sound or feel.
Okay, so
and I don't agree with that, and I would look at somebody free before I would do that.
Turn the stage over to him. Okay, so we need to conclude this session. I really appreciate the conversation.
Please stay
also realized there are 3 workshops on transgender voice issues. I'm so excited about that. And it's a gorgeous day, so take a walk to the Vocal Academy.
The Van Lawrence Fellowship was created by the Voice Foundation and NATS, and I was just about to invite Linda Snyder and Alan Henderson. You're welcome to join us if you wish, as NATS representatives. It was created by the Voice Foundation and NATS to honor Van Lawrence for his outstanding contributions to voice, particularly to recognize the importance of interdisciplinary education, which he fostered among laryngologists and singing teachers for so many years. Fellowship winners are members of the National Association of Teachers of Singing, who are engaged actively in teaching, have demonstrated excellence in their professions as singing teachers, and have shown interest in and knowledge of voice science. The fellowship and the $2,000 award that goes with it are intended to provide opportunities for the fellow to become more thoroughly acquainted with practices, techniques, technology, and people involved in laryngology and voice science. It is hoped that the opportunities and context provided through the fellowship experience will enhance the teacher's ability to do meaningful interdisciplinary research and will encourage the teacher to apply appropriate voice science advances in the studio.